Can everyone hear well? Good morning, good afternoon, good evening to everyone. This wonderful wintry day in Canada, and it's a bit warmer, I believe, in other parts of the world. So my name is Sergey Yegorov. I'm going to talk about our findings from a recent study that was performed in Sub-Saharan Africa, specifically in Uganda, and we looked at the prevalence of malaria in an adult population there. So I'll give you a brief introduction. We all heard about malaria, and we all know that malaria remains a serious health burden globally, but especially in Sub-Saharan Africa. According to the recent WHO report, Sub-Saharan Africa was home to about 90% of all global malaria cases, and approximately same proportion of deaths in Sub-Saharan Africa was attributed to malaria. Malaria is a mosquito-borne disease. It's caused by a parasite called Plasmodium, and the main parasite, a malaria parasite that causes most morbidity associated with malaria in Sub-Saharan Africa is Plasmodium falciparum. So essentially, malaria is an infection of red blood cells. And the typical clinical hallmark of malaria is fever. Many people know that. And fever is typically associated in malaria patients with other symptoms such as headache, sometimes vomiting, and other clinical hallmarks. Laboratory testing for malaria is briefly summarized on this slide. Essentially, the gold standard for malaria microscopy remains to be test remains to be light microscopy, which involves microscopic observation of blood smears. As you can see here, these red blood cells on a smear prepared from a patient probably suspected for malaria. As you can tell from these cartoons, you essentially need at least a good microscope to perform microscopy for malaria, but you also need to be a very well-trained expert in microscopy diagnosis. So light microscopy is still a challenge in some parts of Africa and other parts of the world. So recently, clinical guidelines of many malaria endemic countries have introduced rapid tests for easier and more feasible detection of malaria in the field. These tests are based on a simple principle of immunochromatography, and they detect circulating Plasmodium antigens. They're ideal for field application. It takes a few minutes to get a test, whether negative or positive for malaria. There are other techniques, such as molecular techniques, including PCR, but these techniques are the least feasible in the field, though they are the most sensitive at this point. So malaria in Uganda, since my presentation is actually focusing on this infection in Uganda. In Uganda, Uganda ranks third in total malaria burden globally in Africa and fourth globally. Prevalence of malaria in Uganda varies a lot by region. Essentially, you get different numbers for children, and data on adults is very fragmented. So depending on the study and methods used, you get also different numbers, and recent epidemiological data are very, I would say, unclear for these regions. So the study objective, our study objective, was to assess malaria prevalence among adult women who presented with and without fever to a public health facility in the central region of Uganda between July and December 2015. This region, this is Entebbe, Wakiso, is traditionally known as malaria hyperendemic, with the estimated prevalence based on, again, children of 13%. This was a pilot project, so we didn't start this project essentially as a full epidemiological study. It was a precursor to downstream studies on the immune impact of malaria. Just a few more details. In case you haven't been to Uganda, Uganda is in East Africa, and the region where we were was located on the shores of Lake Victoria, right here. most recent studies on malaria in this region have focused on pregnant women with malaria and also adults with HIV. So effectiveness of recent interventions is not very clear in the general population. Effectiveness of recent interventions on malaria epidemiology. And this region is basically occupied by semi-urban, rural and fishing communities. This is a summary of the recruitment into our study. We had two groups of participants. So the first group of participants was recruited from the outpatient department of Entebbe General Hospital. There were 86 participants. These participants were diagnosed with malaria by the hospital. They had fever, and the malaria diagnosis was done on the basis of light microscopy at the hospital lab. Another group of participants was recruited to look at asymptomatic malaria. So these were women who didn't have any malaria. They were presenting, they were using public health services. So some of them were mothers bringing their children to Mother and Child Health Clinic or any other clinic around the hospital and the Uganda Virus Research Institute. And these women were used to assess the presence of malaria basically in the asymptomatic population. There were 104 women. Women who self-identified as pregnant or HIV infected were excluded from the screening for the study. Testing for malaria. So in those two groups that I just mentioned, so one group had malaria diagnosed by the hospital. The other group supposedly didn't have malaria. They were asymptomatic, no fever symptoms. Both groups were tested on rapid diagnostic tests, first of all, and they were asked for malaria. And they were also tested for pregnancy and HIV. As I will show you just in the next slide, we found unexpectedly, we found high rates of, low rates of rapid tests confirmed malaria among the women with the malaria diagnosis by the hospital. So we were a little bit, I should say, flabbergasted and performed confirmatory testing using light microscopy in a research lab. And also we performed some molecular testing, again in a research lab, in addition to the rapid testing that we conducted. This is a summary of clinical characteristics of study participants in the study. So again, just to reiterate, we had women with malaria diagnosed by the hospital. There were 86 women, and there were women, 104 of them, who presented without fever and used public health services at the clinics. What stands out here right away is that only 2 out of 86 women with a hospital malaria diagnosis were positive on the rapid diagnostic test. So that is only 2.3%. And none of the women in the afebrile group essentially had a positive test for malaria on the rapid test. Interesting and maybe quite intriguingly, the women with malaria had a high proportion of pregnant women as well. The proportion of pregnant women in the no fever group was much lower, probably. So this is a flow chart just showing you in more detail the test algorithm for the women that were diagnosed by the hospital with malaria. So these women, 86 of them, were tested with malaria rapid diagnostic tests, and these malaria rapid diagnostic tests were approved by World Health Organization, or they met the criteria for malaria testing. Out of these 86 women, only 2 were positive on the rapid test, and both of these women were confirmed as positive for Plasmodium falciparum when tested in a research lab with using microscopy, but also using PCR. Out of the 84 women that had a negative rapid test diagnosis, we tested several of them in a subset, and essentially by microscopy, none of these women were positive for malaria. And when a subset of these women was tested by PCR, one of them actually turned out to be positive. But interestingly enough, this sample was positive for Plasmodium ovale, which is a much more rare parasite in the region, and as compared to Plasmodium falciparum. In the no fever asymptomatic group, things are much simpler. Basically, none of the 104 women were positive on the rapid test for malaria. In a subset of women tested, none were positive by PCR or research microscopy. Basically, implying that the rates of malaria in the general population are probably low. So, before I proceed to the discussion, I'd like to mention that our study had some limitations. It was, as I mentioned at the beginning, designed as a pilot and not as a true survey of malaria prevalence. So studies should be conducted, true epidemiological studies should be conducted to really define the malaria prevalence in the region. As I just mentioned, the PCR testing detected a rare parasite, Plasmodium ovale, and I'd like to admit here that the sensitivity of rapid tests for P ovale is actually lower than for Plasmodium falciparum. So in the future studies, those limitations should be taken into account. But nevertheless, in this study, we found high rates of malaria overdiagnosis and treatment at the public health facility, which is a major hospital, major referral hospital in the region. And similar findings are actually observed in other parts of Sub-Saharan Africa and other parts of the world. If you look in, if you just do a basic search of the literature, you will see findings from other groups in Uganda, but also other African countries that also report overdiagnosis of malaria. A similar picture of malaria overdiagnosis was also observed at other public health facilities in the same region, though I'm not talking about this here. The implications of malaria overdiagnosis and overtreatment are several. One of the main ones is that people get may get adverse drug effects if they're treated with the wrong drug. So if someone has a non-malarial infection and they receive anti-malarial treatment, it's probably not going to treat them from another condition. There's also undermanagement of non-malarial causes of fever, which basically comes out of the first statement that I just made. And there is a global concern is drug resistance. If you're treating people with anti-malaria so on a regular basis, drug resistance will probably grow, according to some other research. Another point to make is that we found that rapid diagnostic tests were underutilized by the hospital, mainly due to irregular supply, but also due to lack of confidence in RDT-based results. And we're working with the hospital currently, and I believe that more rigorous quality control for light microscopy and rapid diagnostic use are being or have been mandated at the hospital. No malaria in the asymptomatic population was found, so probably the rates are low in the region. And I'd like to conclude by saying that more efficient allocation of resources may be urgently needed in Uganda, but also in other countries of the world, because malaria still remains a serious concern in pregnant women, also individuals with co-infections. So allocation of resources to the right, to the high prevalence regions is necessary. I'd like to dedicate this presentation to the memory of Dr. George Muir, who was the director of the research clinic. And unfortunately, he didn't get to see the publication that came out as a result of this study. He passed away shortly after I left Uganda. And I'd like to acknowledge the funders, but also the participants and a number of different clinical teams that were participating in the study at Entebbe General Hospital, but at other research institutes, including U of T. Thank you very much, the BSI team, for getting me out here.
All right, thank you, Sergey. I'm just going to have you take a look at this question here in the chat.
So, which one? Okay, so Avinash is asking, since malaria is a serious problem in both Asia Pacific and Africa, many dots, do you think that the two problems are wholly distinct in biological, clinical, epidemiological, and social dimensions? Thanks for the question, Avinash. It's a very global question. Wholly distinct in biological, clinical. So I'm assuming you're referring to malaria in the two regions and how different they are. I think I can only speak from my point of view, from my point of expertise. In terms of biology, Asia Pacific has different Plasmodium parasites. Plasmodium ovale is more, I believe, is more prevalent in that region, part of the world. And an important thing to mention is that Plasmodium falciparum does show up as a more morbid parasite compared to other Plasmodium parasites. So there are distinct differences between the malaria epidemiology in the region. We have another incoming question. Yes, please.
So my question is, do you think if there were two light microscopy evaluations on perhaps on 2 consecutive days or on 2 different time points, you'd have less false positives?
So I assume Dr. Fish is asking whether this is, if this was done at the hospital. So my understanding is that at the hospital, malaria testing is one of the most frequently requested tests. So the lab technicians and very, very frequently the labs doing malaria microscopy are not only under-equipped but understaffed as well. So I think to answer your question, I'm not sure if that would truly improve it in the absence of a good quality control. So if we were to make sure that this testing was constantly controlled somehow, and people were constantly made aware of the actual rates. I would like to know if you have a specific QC method for malaria testing. So I specifically, or our research group, just relied on the QC methods that are already available out there. I know that for malaria rapid diagnostic testing, WHO is trying to roll out a QC system of some kind. But what we did, we used 2 different rapid diagnostic tests just to make sure that we're not biased toward one specific test. In terms of the quality assurance for microscopy and PCR, let's say, I think there are programs in place. So, for instance, the Research Institute in Uganda, Uganda Virus Research Institute, is subscribed to certain quality control programs, and that's actually mentioned in a publication that I referred to during my presentation. And just in case if you're interested in going through this presentation slower, you can go back to the pre-recorded presentations on the BSI website, and this presentation is available there. One last question. Dr. Owino. So the current practice in rural settings in Kenya is that when a patient comes with fever in a high transmission zone, we tend to accept a policy of treat malaria first, since access to lab services might be poor due to scarce personnel. From your experience, what do you see as a way to move away from this, or is it even feasible? I think there are multiple there are multiple debates basically in the literature, and I think we're talking about also 2 distinct groups of patients here. We're talking about young patients, so children, when we're talking about adult patients. So I think this policy really makes sense if you take into account children. So none of us would want to put in danger, a child with the potential, with the possibility of developing, let's say, severe malaria conditions such as cerebral malaria. In adults, I think there's some more flexibility, but in general, there's still a debate, and I know that there's literature advising that it's probably better still to test and treat, and I think that's why the rapid tests are being rolled out, and that's my view of the world. Essentially, rapid test is the way to go for rapid testing.